Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about development and the anatomy of the placenta and the umbilical cord. So, what we wanted to discuss today, the development of the placenta and the anatomy, any placental abnormalities, development and the anatomy of the umbilical cord abnormalities. Let us start our journey. So, what is the development of the placenta? Development of the placenta, as you see in this picture, is formed from two parts, fetal side and maternal side. The fetal side constitutes the trophoblastic cells, or what's called chorion frondosum, while the maternal side is the decidua bizalis. Okay? So, maternal side, decidua bizalis, fetal side, chorion frondosum. Okay, what about the maternal side? It is formed from decidua bizalis, which is the continuation of secretory endometrium becomes decidua, and the part or the site of implantation is called the decidua bizalis. Okay, what about the trophoblast, which is the fetal side? The trophoblast, as you see here, is formed of outer syncytial trophoblast and the inner cytotrophoblast. Also in the other picture here, this is the fertilized ovum, the blastocyst, after implantation. Okay, this is the decidua bizalis here. This is the trophoblast. Trophoblast is formed of cytotrophoblast and syncytiotrophoblast. So, cytotrophoblast and syncytiotrophoblast. And syncytiotrophoblast will form lacunae inside the decidua. Okay? So, what is the decidua? We said the decidua is the secretory endometrium if pregnancy happened. Okay? It is the lining of the uterine cavity. It can be divided into three parts. Decidua bizalis, which is the site of implantation. This is the decidua bizalis, at the site of the implantation. And here, decidua capsularis, which cover the embryo. It is the capsule or the covering of the embryo here. And decidua parietalis, which is the decidua in the remaining part of the uterus. Okay? On the opposite uterine wall, as you see here. Okay? The chorionic villi normally develop only at the area of decidua bizalis, not capsularis and not parietalis. But if abnormally developed in capsularis, it may cause succinturate placenta. Or if developed in the parietalis, also may, and the capsularis, may cause placenta membranacea. So, normally, the chorionic villi will develop properly in the area of the decidua bizalis, while the surrounding chorionic villi will atrophy. Okay? So, the trophoblast will have some processes. These processes develop between 14 to 20 days post-ovulatory, and it consists of primary villi, secondary villi, and tertiary villi. So what is the difference between these? We said that the villi is formed of outer syncytiotrophoblast and the inner cytotrophoblast. Okay? In primary villi, it is only formed of these two cells. While in secondary villi, there is mesoderm inside the villi. So it becomes three layers: outer syncytiotrophoblast, inner cytotrophoblast, and innermost mesoderm. Later on, with time, blood vessel invade the mesoderm, as you see in the picture, this red one. So it becomes the tertiary villi. The tertiary villi. So we have primary villi, secondary villi, tertiary villi. And you know the difference between them now. Okay, look to this picture. This is the fertilized ova migrating from the fallopian tube to the uterine cavity to be implanted like that. Then this blastocyst with outer syncytotrophoblast and the inner cytotrophoblast covering. Okay? And we said that the trophoblast will form the primary, secondary, and tertiary villi. And this is the decidua bizalis, and both the trophoblast and decidua bizalis will form the placenta, as you see here. Okay? The placenta is fully formed at 12 weeks gestational age. And it's the same here. This is the cytotrophoblast. This is the syncytotrophoblast forming this lacunae. The syncytotrophoblast will invade the blood vessel, as we will see here. Then invasion of the blood vessels and also invasion of the endometrial glands will form lacunae. This lacunae will form space called the intervillous space. This is the intervillous space. This intervillous space will be filled with maternal blood. So this intervillous space containing maternal blood coming from spiral arterioles, which are coming from the uterine artery, give the oxygenated blood and the nutrition to the fetus, which will pass through the chorionic villi capillaries to reach the umbilical vein, which carry the oxygenated blood and the nutrition to the fetus. On the other side, the umbilical arteries, two umbilical arteries will carry the deoxygenated blood and the toxins from the fetus and the metabolites from the fetus to the placenta to be excreted. Okay? So what about the anatomy? Anatomy of the placenta. We know the placenta is formed of fetal part, which is the chorion frondosum, this part, the chorionic villi, and maternal part, which is the decidua bizalis. Both of them will form the placenta. So what about the size of the placenta and its shape and weight? The placenta usually normally implanted in the upper half of the uterus or upper uterine segment, anterior or posterior. Posteriorly in 60% of cases, anteriorly in 40% of cases. So this is a normal implantation of placenta, high up in the uterus, or sometimes in the fundus. Okay, this is as regard the side. What about the shape? It is round or ovoid in shape. As you see here, it is round. Okay, the size, it is 20 centimeter in diameter, and its thickness is 2 to 4 centimeter, and its maximum thickness at the center, and the thickness decrease near the periphery. It has a maternal surface, this one, and the fetal surface, this one. The weight of the placenta is 500 grams. This picture shows you the maternal and fetal surface. This is the fetal surface. As you see, it is grayish white, glistening, smooth, as you see, with the insertion of the umbilical cord here. This is the fetal surface, and normally the umbilical cord in 73% is eccentric, while in 18% it is central, while it is marginal in 7% and velamentous in 2%. Okay? Okay. You can see the radiating branches of the umbilical vessels through this maternal fetal surface, as you see. In the other picture here is the maternal surface. As you see, it is rough, formed of cotyledons from 15 to 20, grayish red in color, sometimes white physiologic infarction, small, present. There is remnant of decidua giving it the grayish red color. Okay. So what about the fetal membrane? Please look to this picture. We have the chorion and the amnion. The chorion is the outer one, as you see. The chorion is the outer one. The surface is in contact with the uterine wall. It is less transparent than the amnion, and it ends at the margin of the placenta, as you see here. This is the chorion. While the amnion is the inner one, it is transparent, glistening, lining the chorionic membrane, and it is considered the innermost membrane. It covers the fetal surface of the placenta and the umbilical cord. It covers the fetal surface of the placenta and the umbilical cord. So what about the placental abnormalities? Maybe the abnormalities in shape of the placenta, in the site of implantation, in its early separation, or presence of infarction or cysts. So there is many abnormalities can be diagnosed in placenta, like placental shape abnormality, like succintoriate loop, as you see here in this picture. This is the succintoriate loop. Why it happened? Due to failure of atrophy of capsular villi. You remember when we said the chorionic villi at the region of the decidua capsularis usually must be atrophied. If it is failed to be atrophied and continue to develop, may lead to this succintoriate loop. Clinical importance of this succintoriate loop may lead to postpartum hemorrhage, may be retained inside the uterus also after delivery of the main part of the placenta. The other abnormality is bilobate placenta occur when implantation occur at the sulcus, at the border of the uterus, okay, right or left. So it simulates that the placenta is divided into two parts, so we call it bilobate placenta. But if we have multilobate placenta, this may happen if there is cavity abnormalities, something abnormal inside the uterine cavity, causing the multilobate placenta. But if it is bilobate, mostly this is a sulcal implantation. Implantation occur at one of the uterine border. Another placental shape abnormality, circumvallate placenta, as you see in this picture. Why it happened? Because the chorionic membrane don't insert at the edge, but at some distance inwards from the margins. This will result in thickened placental edge and rolled up and the central depression. Thickened placental edge, as you see, and rolled up and central depression. Is there any risk with circumvallate placenta? Yes, may be associated with placental abruption, preterm delivery, and small for gestational age. Another placental shape abnormalities is what's called placenta membranaceae, as in this picture. Here its implantation occur at a wide area, and the chorionic villi at the decidua capsularis bursts. So the placenta will be large in size and thin, covering a large area inside the uterine cavity. So the possibility of occurrence of placenta previa is high, and occurrence of velamentous cord insertion in the cord blood vessels is high, which may cause severe antepartum hemorrhage from velamentous vessel, or especially if it causes vasa previa, or from placenta previa. Another abnormality in the placenta, abnormality for the site of implantation. We said that the normally implantation of the placenta occur at the upper part of the uterus in the anterior wall or posterior wall, or while in placenta previa implantation occur in the lower uterine segment covering the cervix or internal os here, and we have four varieties: complete previa, partial previa, and marginal and low-lying previa. Within 30 millimeter from internal os, the lower edge of the placenta can be seen by ultrasound in case of low-lying placenta. Okay, so during implantation, the villi, the chorionic villi, will develop over and covering the cervical opening. The maternal surface of the placenta, as you see in this picture, may show hemorrhage, okay, or fibrin deposition, as you see here. So hemorrhage or fibrin deposition on the maternal surface. Another abnormality for placenta is abnormal in its attachment to the uterus. Okay, as you see in this picture, there is invasion of chorionic villi to the muscle wall. This chorionic villi may be just attached or little invasion, and we call it accreta, this one, which is the commonest, this one. Okay, but if invasion becomes more inside the muscle wall, it is called increta. And if invasion invade more and extend for the whole muscle layer of the uterus, and even reaching the peritoneal covering or nearby organ, it is called percreta. It is one of the most dangerous complications in obstetrics, and it occurs especially if there is some risk factors like previous cesarean section or previous scar in the uterus due to myomectomy, or due to ruptured uterus, or due to placenta previa. So the commonest risk factor is uterine scar and placenta previa. As you see in this picture, this is placenta pericreta invading the muscle wall of the uterus, still reaching the peritoneum. Another complications or abnormality in the placenta, which is the premature separation of the placenta. Normally, we know that the placenta start to be separated after the delivery of the fetus with the delivery and of the placenta at third stage of labor. But what if part of the placenta becomes separated prematurely? This is called abruptio placenta or accidental hemorrhage. It may be revealed or concealed or mixed type. Separation may occur at the center only with large retroplacental clot, as in this area, or separation may occur at the edges, causing bleeding, which will cause revealed accidental hemorrhage, or if the blood trapped behind the placenta with large blood clot is called the concealed accidental hemorrhage, or the case may have both of them. One of the commonest causes is preeclampsia and hypertension with pregnancy, and trauma and short cord. So different causes can cause abruptio placenta. Another abnormality for placenta is the hydatiform mole. As you see here, the uterus is filled with grape-like vesicles, which can be seen by the ultrasound as a honeycomb appearance. And in this picture, you can see the vesicles filling the uterine cavity. This is the mole or pregnancy. This hydatiform mole may be complete mole or pregnancy or partial mole or persistent trophoblastic tumor. Placental cyst, one of the other abnormality that may discovered in the placenta. Cyst, especially on the fetal surface of the placenta near the insertion of the umbilical cord, as you see here in the picture. This is the placental cyst, and this is how it looks by ultrasound. This is the placenta, and this is the placental cyst. Usually it is a benign and not risky. Don't afraid about it, because mostly it is benign and not causing any harm to the fetus or to the mother. But rarely, if it is larger than 4.5 centimeter, some reports said that it may be associated with intrauterine growth restriction. Large placenta or placentomegaly. If the placenta exceeds in its weight 600 grams, we call it large placenta or placentomegaly. This case may be associated in cases of syphilis, in cases of diabetes with pregnancy, in cases of alpha thalassemia, erythroplastosis fetalis, blood group incompatibility. Placental infarction, whatever red infarction as you see here in the picture, or white infarction, okay, due to fibrin deposition, okay, or hemorrhagic or red infarction due to thrombosis in the intervillous space and maternal vessels of the decidua. Okay, the causes may be due to preeclampsia or hypertension with pregnancy, or diabetes mellitus, or chronic nephritis. The fibrinoid degeneration of the trophoblast occur with calcification and infarction, and there is a spiral artery occlusion. If this infarction affecting large area, it will cause intrauterine growth restriction and intrauterine fetal death. But small infarcts, especially the white one, may occur without any harm. Okay? Let us go to the umbilical cord, which is a tubular structure, as you see in the picture, connecting the fetus to the placenta. Connecting the fetus at the site of the umbilicus to the chorion or to the placenta. It develops from the mesodermal stalk, as you see in the picture, connecting the inner cell mass with the chorion. This is the chorion. This is the chorionic plate, and this is the inner cell mass. So connecting this mesodermal stalk, connecting the inner cell mass with the chorion. Okay, what about its length? It is about 50 to 70 centimeter. You can see the umbilical cord here in the picture, connecting the umbilicus to the placenta. This is the fetal surface, of course. From 50 to 70 centimeter, and its diameter about 2 centimeter. It is glistening because it is covered with amniotic membrane, which is transparent and glistening. So, what is the content of the umbilical cord? It is formed of Wharton jelly, which is of mesodermal tissue origin, in which there are 2 umbilical arteries and 1 umbilical vein. As you see here, 2 umbilical arteries and 1 umbilical vein. The 2 umbilical arteries carry the deoxygenated products, blood, and toxic products, and the metabolized to be excreted through the placenta. from the fetus to the mother, while the umbilical vein carry the oxygenated blood and the nutrition to the fetus from maternal side to the fetal side. So the umbilical vein is the one which carry the oxygenated blood and the nutrition to the fetus. Any umbilical cord abnormalities? Yes. Maybe in the length, maybe too short, maybe too long, as in this picture. This is the too long. If exceed 80 centimeter, what is the risk of being too long? Maybe entanglement around the fetal neck, causing asphyxia and obstruction of the umbilical vessels. Maybe forming nodes, true nodes. Maybe prolapsed after rupture of membrane through the cervix, and the prolapsed cord is an emergency situation and causing fetal distress and maybe intrapartum death. A wild short cord, as in this picture, if it is less than 50 centimeter, and the complication that may happen is uterine inversion during the traction on this short cord and the inversion of the uterus during labor, maybe abruptio placentae, premature separation of the placenta because of short cord and traction on the placenta, or avulsion or rupture leading to fetal death due to hemorrhage and ischemia. Another abnormality in the umbilical cord is the presence of single umbilical artery, which occur between the range 0.2% to 0.8% as an incidence. It may be isolated single umbilical artery or may be associated with chromosomal abnormalities and congenital anomalies. And you should know that the presence of single umbilical artery, the possibility of occurrence of chromosomal or association of chromosomal abnormalities is 15 times the normal. Okay? So, what is the risk of the presence of even isolated single umbilical artery? Intrauterine gross restriction, intrauterine fetal death, prematurity, and fetal mortality, intranatal or prenatal. And we said that single umbilical artery, when you discover it during pregnancy, during screening, during mid-trimester and third trimester, you should search for congenital anomalies. And the commonest congenital anomalies that occur is renal anomaly, cardiovascular anomaly, and the musculoskeletal anomaly. It is of importance to note that the single umbilical artery is more common in infant of diabetic mother, threefold, in the white people, twofold increase, and in multiple pregnancy, fivefold increase. In this picture, you can see the difference between normal cord and single umbilical artery cord. Here, there is two arteries and one vein. This is normal. Here is one artery and one vein. This is abnormal. This is what's called single umbilical artery. Of course, you can diagnose it using Doppler ultrasound during antenatal care screening in second and third trimester. Another abnormality for umbilical cord is the true node of the umbilical cord. So, if we said there is true node, so we should know that there is false node. So what is the difference between true node and false node? As you see in the picture, this is the true node with complete or partial obstruction of the blood flow through the umbilical vessel and can cause intrauterine fetal death. Why it happened? Because the fetus passed through the loop of long cord resulting from active fetal movement. And this is also one of the complications of abnormally long cord. What about the false note in the umbilical cord? Just thickening in Wharton jelly, as in this area. So it is not pathologic and not associated with any complications. So it is not true note, it is false note. It's just thickening in Wharton jelly. Another abnormality is the velamentous insertion of the cord, as you see in the picture. This is the branching vessels passing through the membrane, okay, traversing the membrane before inserting into the fetal surface of the placenta. Why it is dangerous? Because it is liable for injury and the hemorrhage, because it is just moving in a very thin membrane, so it is not protected. While the large vessel should be protected by the placental tissue. So it's moving through the surface like that, making it at risk of being injured or teared. Okay? And if it was crossing the cervical os, as in case of Vasa previa, it may cause horrible bleeding and will be of fetal origin. As you see another picture here, also there is velamentous insertion of the umbilical cord, insertion in the membrane. The umbilical vessel passes through the membrane, as you see here. Another abnormality is the marginal cord insertion. How can we define marginal cord insertion? If the placental cord insertion within 2 centimeters of the placental edge. If beyond the 2 centimeters, it is not marginal. Okay? But marginal cord insertion if within 2 centimeters of the placental edge, as in this picture, as you see. It was found there is association between marginal cord insertion and intrauterine growth restriction and the preterm labor and also monochorionic twins pregnancy. Vasa previa. Vasa previa occur when, as you see in the picture, one or more blood vessels from the umbilical cord, this one, or placenta, so the vessel from umbilical cord or the placenta, cross the cervix, this is the cervix, cross the cervix underneath the baby or the presenting part here, as you see. So this vessel crossing above the cervix underneath the baby. Why it is dangerous? Because it's liable to be injured and horrible bleeding may occur and fetal hemorrhage and the intrauterine fetal death. And of course, the blood here of fetal origin. And we can diagnose it by doing certain investigation, detection of hemoglobin F, and so on. So it is an emergency situation, of course. Vasa previa can be diagnosed by Doppler ultrasound, and you should search for it in high-risk cases, especially with placenta previa cases. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University.